Assalamualaikum and hi everyone. This is the lecture for the third part of drug-induced disorders. So in this lecture, we are going to look at the drug-induced hematological disorders or the blood disorders. So at the end of this lecture, you should be able to identify the types of drug-induced hematological disorders, identify the common drugs that might be associated with all the types of drug-induced hematological disorders, discuss the symptoms and presentation of this event, and suggest appropriate treatment, monitoring, and preventive measures of this reaction. So some agents might cause predictable hematological diseases, for example, antineoplastics or chemotherapy drugs. But for other drugs, it may induce idiosyncratic reactions that are not necessarily related to the drug's pharmacology or mechanism of action. And these hematological disorders associated with, these drug-induced hematological disorders are commonly associated with significant morbidity and mortality. For example, aplastic anemia was the leading cause of death. So it followed by thrombocytopenia, agranulocytosis, and haemolytic anemia. So the risk of getting this ADR and the risk of death following this ADR is higher with increasing of age. So elderly patients are at higher risk to get this type of ADR and are at risk of fatalities due to this ADR. So drug-induced hematological disorders can affect any blood cell lines, including white blood cells, the WBC, red blood cells, and also platelets. So this is the origin of these three types of blood cells: the neutrophil, which is the white blood cell, red blood cell, and platelets. It comes from the stem cells. So during the differentiation, each of them have a different characteristics and function. So the origin is from stem cell, in which each of these cell actually differentiates into a specific morphology and characteristics to become three types of blood cells, which are neutrophil or the WBC, red blood cells, and platelets. So WBC is important to fight infection, red blood cells to carry oxygen, while platelets are important for the blood clotting. So because we have three types of blood cells, so we have several types of hematological disorders. First is drug-induced agranulocytosis, which is involving the WBC, drug-induced thrombocytopenia involving platelets, and hemolytic anemia involving red blood cells. And we also have megaloblastic anemia, and lastly aplastic anemia, which involve all three of the blood cells. So for drug-induced agranulocytosis, we have 5 different types of WBCs. We have neutrophil, eosinophil, basophil, monocyte, and lymphocyte. And I believe you already learned about these types of WBCs before. So we have different types of definition here when it comes to agranulocytosis, depending on the type of WBC affected. For example, for leukopenia, it is defined as the total white blood cell of less than 3,000 per microliter, while neutropenia only affect the neutrophil count of less than 1,500 per microliter, while granulocytopenia affects only the granulocyte count. And for agranulocytosis or severe neutropenia, it is defined as a reduction in the number of mature myeloid cells in the blood, including granulocyte and immature granulocytes, to a total count of 500 cells per mil or less. And the incidence of this drug-induced agranulocytosis is between 1.1 to 12 cases per million inhabitants per year. So it's not that common. So the symptoms for agranulocytosis include sore throat, fever, malaise, weakness, and chills. So it can appear within days to weeks after initiation of therapy, and it usually resolves over time with with supportive care and management of infection, because the role of neutrophil or role of WBC is to fight infection, so the patient might have a higher risk to become infected. And the neutrophil count will achieve recovery between 4 to 24 days after the stopping of the medication. So the example of drugs that might cause this reaction are penicillin, quinidine, high-dose beta-lactam antibiotics, carbamazepine, valproic acid, clozapine, cyclopidine, propioniuracil, or metimazole. So each of these medication might cause agranulocytosis by different type of mechanism or etiology, as you can see and read here. So the treatment in general is to remove the offending drug, and also symptomatic treatment. For example, if the patient is having infection, we have to give antibiotics. And also, if necessary, we can give the patient colony stimulating factors like sagramorcin or filgrastim. So it is recommended only in patients with neutrophil NADE or less than 100 cells per mil. For the second type is drug-induced thrombocytopenia, which is the blood disorders affecting the platelets. So the definition for this thrombocytopenia is that there is a low count of platelet of below 100,000 cells, or more than 50% reduction from baseline values. So the incidence is also quite rare, 10 in 1 million of population. So the early phase of this reaction is, so the early phase of this ADR, we can see that the patient have an increased bruising. So during the early phase of this ADR, the patient might have increased bruising, so they can bruise easily as compared to before. Petechiae, ecchymosis, or epistaxis, nose bleeding. And also later phase, and at the latest phase, the patient might have a bleeding of the mucous membrane and purpura. The example of drugs include quinidine, quinidine, sulfonamide, rifampicin, heparin, vancomycin, penicillin, cephalosporin. So these are the groups of antibiotics, cold compounds or prokinamide, antineoplastic, and heparin. So we can see that there are different mechanism or etiology of thrombocytopenia depending on the types of the drug. For example, for antibiotics, it can react through Hampton type immune reaction, and usually occurs at least 7 days after the initiation of the drug. And it can recover within 1 week of stopping of the medication. For the gold compounds or prokinamide, so there is a formation of specific autoantibodies that bind to the platelet and causing the platelet to destruct. So for antineoplastic, it acts through a direct toxicity reaction, and there is a suppressed thrombopoiesis or the formation of the platelet, in which it will reduce the number of megakaryocytes in the bone marrow, so the production of platelet is reduced. So for heparin, it can occur by type 1 or type 2 of immunologic reaction. So these are the details of heparin-induced thrombocytopenia through type 1 and type 2 reaction. Type 1 is non-immunologic reaction, which is mild and reversible. It occurs in 10 to 20% of patients on heparin, and it can occur for the first 2 days of therapy, in which platelet count may slowly return to baseline after that, and it is usually patient is usually asymptomatic. But for type 2, which involve immunologic reaction, it can be more severe, and it is also less common. And platelet count generally begins to decline within 5 to 10 days after the initiation of heparin. So patients with recent major surgery are at a higher risk to develop this thrombocytopenia induced by heparin. The complications of this thrombocytopenia is that the patient might have thrombosis and will continue for days to weeks after the heparin discontinuation. So there is a latent effect even after the heparin is discontinued. Heparin-induced skin necrosis and venous gangrene might also occur on the limbs of the patients. For the management, the goal of the management is to reduce the risk of thrombosis or thrombosis-associated complication. We want to remove the offending drug and give the alternative anticoagulant like the direct thrombin inhibitors, for example, lepiridine, agratroban, or bifalirudin. For the third types of drug-induced hematological disorders is the drug-induced hemolytic anemia. And we have two types of mechanism, which is through immune or the oxidative reaction. In hemolytic anemia, there is a premature red blood cell destruction, or we call it hemolysis. So anemia occurs when the rate of destruction of RBC exceeds the rate of production. So there is a lower level of red blood cell or hemoglobin in the patient, and it can occur either because of the defective RBC or abnormal changes in the intravascular environment. So this is the normal white blood cell, platelet, and the red blood cells. In hemolytic anemia, the red blood cells have a defected membrane in which it will rupture easily. So the symptoms of hemolytic anemia is that the patient might feel fatigue, malaise, pallor, which is pale, and also they can experience a shortness of breath, and it can be caused by immune or metabolic reaction. The types of hemolysis is intravascular hemolysis, in which the lysis of RBC happens in the blood circulation, or extravascular hemolysis, in which the red blood cells is being ingested by the macrophages. So these are the symptoms of anemia. We can see that, and the red ones are when the patient is having severe anemia. So the patient might be pale, having shortness of breath, muscular weakness, and generally fatigue, and having dizziness, and they can also faint if the anemia is severe, and they might also have palpitation or rapid heart rate, and at the severe cases, they might have angina or heart attack. So I mentioned before, we have two types of hemolytic anemia. It's either immune or oxidative, through oxidative reaction. For immune reaction, the immunoglobulins will bind to the antigens on the surface of the RBC and initiate their destruction through the complement and mononuclear phagocytic systems. So it involves the immunoglobulins. So it acts through. So in this immune hemolytic anemia, it involves the immunoglobulins, in which this IgG or IgM will bind to the antigens on the surface of RBC and initiate their destruction. We can diagnose this immune hemolytic anemia through COMS test. The example of drug that might cause this reaction are high-dose penicillin or cephalosporin, quinidine, sulfonamide, or methyldopa, levodopa, mefenamic acid, or diclofenac. So these are the reaction that occurs in the direct antiglobulin test and indirect antiglobulin test in order to detect the immune hemolytic anemia. And the management of this ADR is of course the removal of offending agent, and we want to give supportive care to the patient, in which we can give folic acid supplement or glucocorticoid. And patients who do not respond can be managed with azathioprine or cyclophosphamide to reduce the immune reaction. And also in other severe cases, monoclonal antibody and immunoglobulin treatment can be given. For oxidative hemolytic anemia, for example, in G6PD enzyme deficiency, it is an inherited condition through sex-linked chromosome, and a deficiency in G6PD reduces the ability of glutathione to help red blood cell to deal with the oxidative stress. So when RBC are exposed to drugs which can cause oxidation, the cell membranes becomes damaged, and the hemoglobin becomes oxidized and hemolyzed. So the example of drugs are nitrofurantoin, sulfamethoxazole, and primaquine. So in the normal condition, this 6-PD enzyme is important to help the body to eradicate the oxidative stress. So if the patient do not have this enzyme, whenever they are exposed to food or drugs that might cause this production of glutathione, so they are prone to have the oxidative, so they are prone to get the effect of from the oxidative stress, and mainly it will affect the RBC and causing the destruction of RBC. The degree of hemolysis and causing the hemolysis of RBC. The degree of hemolysis depends on the severity of the enzyme deficiency and also the amount of the oxidative stress. So next is the drug-induced megaloblastic anemia. So this is when the development of RBC precursors called the megaloblast in the bone marrow is abnormal. So it can be caused by the deficiency in either vitamin B12 or folate. Deficiencies in either vitamin B12 or folate are usually responsible for the impaired proliferation or maturation of the hematopoietic cells, and it results in the low production of RBC. And also some drug might also have the same effect. So clotrimazole, for example, has been reported to cause drug-induced megaloblastic anemia with low or high doses, particularly in patients with partial vitamin B12 or folate deficiency. So predisposing factors here are when the patient is having a deficiency in vitamin B12 and folate deficiency, and the intake of the drug that might cause this drug-induced megaloblastic anemia will increase further the risk of the patient to develop this reaction. The treatment, if it's caused by chemotherapy, the patient needs to be given folinic acid up to 4 times a day to prevent this type of ADR. And if it's caused by other drugs, the patient can be given folic acid supplementation. And lastly is the drug-induced aplastic anemia. It is a very serious disease, and it is also rare. The incidence is between 2 to 7 cases per million inhabitants. The incidence is higher among patients less than 30 years old and more than 60 years old. And the definition of aplastic anemia is when the patient is having 2 of the following criteria. Presence of all of these conditions of anemia, neutropenia, and thrombocytopenia is called pancytopenia. The mechanism can either be one of these 3 mechanisms. So basically, there is a damage in the hematopoietic stem cells before their differentiation to the to committed stem cells, and it can act through direct, dose-dependent toxic effect, idiosyncratic, or drug or metabolite induced immune reaction. So for direct or dose-dependent toxic effect, there is a suppression in the proliferating cell lines. So we can see that more in cases with chemotherapy drugs or chloramphenicol, and the metabolites of phenytoin or carbamazepine may also bind to the macromolecules of the cell and can cause direct toxic effect of the cell, eventually causing cell death. For idiosyncratic, which is not dose dependent, for example, chloramphenicol, it can also will interact with the DNA in the stem cell and causing cell death as well. The symptoms may appear from days to months after the initiation of the offending drug, and average is 6.5 weeks. Neutropenia will present first, followed by thrombocytopenia, and finally anemia. The low white blood count. So neutropenia is a low white blood cell count. So basically, the patient might be presented with the symptoms of neutropenia first, like sore throat or fever, and followed by thrombocytopenia. Maybe the bleeding or petechiae will occur subsequently, and followed by anemia. So the management will be to initiate. The management should be initiated immediately once the patient was diagnosed with this condition. We want to remove the offending agent, and we want to give supportive care for the patient, for example, antibiotics for infection, and we want to transfuse them with erythrocyte, the red blood cell, and the platelets. And for the treatment, we want to for the treatment, the patient can be given this stem cell transplantation for young patients, or immunosuppressive therapy. And in general, when we're dealing with drug-induced hematological disorders, of course, we want to remove the offending agent first, and then we want to give the patient with supportive care. For example, for neutropenia, we want to give antibiotics to cover for infection, because the patient have a reduced ability to fight for infection, and also blood transfusion if the patient's having anemia or thrombocytopenia. And also at the same time, we want to give alternative treatments to the patient if required or necessary. So these are the references that I used for this lecture. Thank you very much for watching.